Gentle disclaimer to all of our listeners. All medical information mentioned in this podcast is purely informational. It is not individualized medical advice. Please follow up with your physician or medical practitioner for individualized care specific to your needs. Thank you.
Hello, everyone, and welcome to the Know and Do Better podcast. My name is Dr. Melanie Carminati, and today we have a special guest, Dr. Karolina Pekala. I want to just give a heads up to everyone, to all of our listeners. This is a sensitive topic. Anyone who's listening, we will be discussing eating disorders. So, Dr. Pekala, thank you so much for joining me.
Thank you so much for having me. I really appreciate it. It's great to speak with you in this capacity.
For those listeners, Dr. Karolina Pekala is a clinical psychologist who specializes in eating disorders, anxiety, adolescence, confidence, and self-esteem. She gained extensive experience in disordered eating while completing her postdoctoral fellowship at Cambridge Eating Disorder Center. She approaches therapy in a holistic way, utilizing with dialectical behavioral techniques, DBT, psychodynamic principles, and family relational patterns, along with creative techniques such as hypnosis to help clients achieve their goals. So, Dr. Pekala, I wanted to start off the conversation with just asking you, how do you define an eating disorder? What are some factors that come into consideration when diagnosing someone with an eating disorder?
Certainly. So what I'll do is I'll limit the scope of our discussion to the common disorders I work with, which include anorexia, bulimia, and binge eating, including those that may be considered atypical in nature or of limited frequency in terms of how often someone engages in a behavior, such as binging or purging, for instance. And I'll go into these in a little bit of detail. So anorexia and bulimia are frequently marked by a distortion in the way one views one's body. For instance, there are a lot of really great studies of individuals with eating disorders who look at photos of body shapes and are asked to choose the ones most similar to them. And they will almost always select shapes significantly larger than they actually are. There's a really big distortion in the way the self is viewed, both in terms of character often and just the physical self. And it can overlap with body dysmorphia quite a bit. And there is also a great amount of preoccupation with food and appearance. And a person with anorexia, whether underweight or of normal weight or higher weight, often has a hamster wheel of thoughts continuously running through their head. They may be mentally scanning, tracking, counting calories, food, nutrients, carbs, sugars, what they ate earlier, what they can eat with friends at dinner later tonight. They may think about what they consumed the previous day and about restricting during the day. And a common theme of anorexia, as you may have noticed, is just mental exhaustion due to the immense amount of real estate thoughts regarding food consumed in the mind. There's also a great fear of gaining weight and behaviors utilized to prevent it or to prevent weight restoration, such as restriction and overexercise. And a person with anorexia also often does not want to let go of the eating disorder. They often seek treatment at the behest of a partner or a parent. I often view mental disorders, all of them really, as ego-syntonic or ego-dystonic. So in the former, if a mental disorder is ego-syntonic, it means it is a part of one's world, and the individual often does not want to give it up. So for instance, I have worked with individuals, patients whose anorexia was so severe that they were malnourished, dying, and have needed to go on olanzapine, which is a newer antipsychotic, because they were absolutely convinced to the point of delusion that their physical presentation was overweight or even obese and that they were fat. So anorexia is one of the deadliest, if not the deadliest mental illness. And secrecy, control, and shame, these are hallmarks of many eating disorders. And with anorexia, restriction and thoughts of self-loathing are especially present. And the person, again, since it's ego-syntonic, the person with anorexia typically does not want to let go of or treat the eating disorder, which is what makes it so deadly. So in contrast, a person with bulimia or binge eating is distressed by their eating disordered behaviors. It is egocentric, which means they do not want it to be a part of their world or their life, and so they are more likely to seek treatment. There is also a lot of secrecy here as well, and perhaps even secret eating or hiding the quote unquote evidence of a binge by putting trash on top of candy wrappers, for instance. And individuals who purge may also find that their ability to do so is altered based on their environment. For instance, if they're on a family vacation or a trip with friends, they may not purge for a whole week, even if normally they do so daily, because they don't want other people to find out about it or to hear about it. And other themes that are very common with eating disorders include control. So someone with anorexia may feel out of control in their life, be it work stress, school stress, a response to trauma. And in order to attain a sense of control, it may be that they choose to restrict in order to achieve that. There's often a sense with eating disorders that if I do ABC, or if I'm perfect and thin, then bad things won't happen or wouldn't have happened. This is something I can control. Perfectionism is a common theme, especially with regards to work, academics, athletic achievement. Control is also seen in bulimia and binge eating. In a binge, this is a curious thing. It's defined as more than what a person would reasonably be expected to consume within a discrete amount of time, say like 2 hours. And it's also really important as a clinician to ask, oh, what's a binge like for you? So for instance, one person may say, oh, I had too many chocolate chip cookies. That's a subjective binge. That's not a real binge. An example of a binge would be ordering nachos, quesadillas, having a bag of party-sized potato chips, and then ice cream. So again, and then there's that sense of that lack of control. I must keep eating. I have to keep going. It's like I just lose that control. And I'm sure you're noticing that eating disorders are so symbolic and emotional. A binge may be to self-soothe, to quell anxiety, panic, or fear. And with binging, it may be symbolic of stuffing things down. I'm really anxious and scared and don't want to feel this. I want to be numb. Or I'm angry at my spouse and I can't express it. I can't say how I feel. So I'll express it with my body and my eating behavior. I'll just stuff it down. And it may also feel like a high during the binge, often pleasurable emotions, but is often followed by shame, guilt, and regret. And these eating disorder behaviors may have become automatic due to our upbringing. It may have been the only way we could cope at the time with circumstances that were unbearable. And this is the thing about what differentiates binge eating disorder and bulimia, is that with bulimia, we have compensatory behaviors. And another thing people might think is like, oh, I'm not bulimic. I don't purge. It can be anything to compensate for the binge. So for instance, it could be exercising for 5 hours the next day. It could be something like, using laxatives, diuretics, or not eating the next day at all. And then without eating, we may fall into the restrict binge cycle when we are voraciously hungry at the end of the day. Often the first stage in any eating disorder treatment is to really normalize and stabilize eating throughout the day with meals and snacks. So these are the really common themes and considerations looking at eating disorders. And I can also tell you how the DSM, or how the Diagnostic and Statistical Manual of Mental Disorders views eating disorders, because some of the language can be a little tricky.
Sure.
But the DSM-5 views eating disorders as a disturbance in one's eating behaviors that lead to a significant impairment in health, social, psychological, or work functioning. What does that mean in practicality? Health can be impacted in that the enamel from teeth is completely worn away from stomach acid from purging. And dentists are often the first to know if someone is purging. Women may have trouble conceiving. Some people, may have really severe acid reflux the day after a binge. So these are all health factors that's impacting. And then also in terms of socialization, someone may not want to date or be physically intimate with someone because of how they look or how they think they look.
Wow.
Or it can be really hard to work because it can be hard to concentrate or focus when we're malnourished or if we're just constantly fixated on food. And psychologically, the thoughts of food, restrictions, scales, numbers, appearance really predominate and cause a negative view of the self. And then kind of the last point regarding this is that each eating disorder is really unique in its presentation, treatment, and outcomes. So we can't be diagnosed with both binge eating and bulimia, for instance. And we also wonder about the difference between eating disorders and disordered eating. What's that? And so the distinction is the amount of distress it causes the individual, how much it impacts their lives, thought preoccupation, their relationships, and of course, their relationship with themselves and their bodies.
Sure.
And the emotional valence tied to food and eating disordered behaviors is incredibly strong. And also with diagnosis, we look at the frequency and duration of behaviors, if it's atypical in presentation in terms of diagnosis. For instance, an individual may be told by their primary care that they are obese, yet they have all the symptoms of anorexia and meet the diagnosis. So this person would have the diagnosis of atypical anorexia nervosa. And this is one of the most common myths I see within the realm of eating disorders in our society in general. That if someone fits a certain image, one cannot have an eating disorder. My friend ate pasta last night at dinner. Guess what? May have been the only thing he ate all day.
Want to just pause to, emphasize that the underlying root challenge is the mental illness, right? So first thing about eating disorders, we're like, oh, it's around food, but it's behavior, like you're saying. It's the distorted behavior regarding food. And all of this just comes back to psychological well-being.
Yes, and eating disorders are a mental illness in and of themselves. And there are many things that co-occur with them. So you're so right.
So you mentioned a few emotions or symptoms or anxiety, the need for control, the other symptoms and possible co-occurring disorders with eating disorders. Can you touch on that?
Definitely. So some common co-occurring disorders that overlap with eating disorders are anxiety, depression, and trauma. And a common thread I see is that these disorders impact the way we see the selves and how we see the world. Just like how having an eating disorder often changes the way we see ourselves. And I often view eating disorders as a relationship like any other, especially at times a commanding one, with all the negative automatic thoughts that may run through one's head when in the thick of it, just like with anxiety or rumination with depression or intrusive thoughts with PTSD.
What then I want to talk about, because everything that you're saying, I know from my experience as a dancer growing up, classmates, dancers that were training with having different types of eating disorders. And I feel, there still is a large prevalence. I know now too, as a professional, because I had the opportunity to work with the Alvin Ailey School of Dance. And it's not specific just to this organization. It's across the board in dance that we see, the prevalence of eating disorders and disordered eating behaviors. And I remember we are very proactive and do injury prevention screening with the Alvin Ailey entering class dancers and at Fordham University. And one of the components that we do, we would utilize the EAT score or the outcome measure, which was essentially just like a questionnaire, but this was used to see if anyone was falling into a category of potentially having an eating disorder. But when we would then refer, it was that trifecta of care. It was psychologist, psychiatrist, registered dietitian, and then adolescent medicine. Because as you mentioned with some of the eating disorders, when you are not getting the nutrients into your body, this affects your bones. It affects the health of your teeth. It affects your gastrointestinal system. It affects your reproductive system. So, your menses, your menstrual cycle. I remember distinctly too, one of my trainings in Miami, having someone who was in a rehab center specific for eating disorder. She was 32 years old and had osteoporosis. And this was not because she had any underlying disease or diagnosis beyond the eating disorder. So just from that lack of nutrition in her body, skeletal system went into the state of osteoporosis, and this can be really dangerous, especially at a young age. So I wanted to just hear from you, how do you incorporate or how do you work with other practitioners in regards to being able to address that trifecta and address some of the medical concerns and then the dietary concerns? How do you collaborate with other practitioners?
Certainly. So at my postdoctoral fellowship, based on the level of care, whether it was residential, partial hospitalization, we would have a treatment team, just like you described. There would be a nutritionist, a prescriber, and a therapist as part of the patient's care team. And when a person transitions to intensive outpatient or just regular outpatient, I often collaborate or recommend seeing a nutritionist or a prescriber, and often a PCP, because that's often lacking. Now that I am in a group practice that specializes in eating disorders, I facilitate collaboration really based on patient needs, especially if they are looking for a holistic approach. I also refer to other practitioners I feel may be a good fit for them. In addition, I often write letters, whether it's for school or for work, or to provide recommendations for school counselors, and sometimes just to check in and let them know the progress. And for patients who feel shame regarding their weight, there's often a great fear of seeing doctors, even primary care, and putting off really necessary preventative care. So there are a variety of techniques I use within therapy to help them obtain that medical care, to help them feel supported, from talking about things like blind weights to messaging doctors ahead of time, or even setting up an appointment while with me in session.
Do eating disorders run in families? And is it like environmentally influenced or genetically influenced?
It can be both. Studies have shown that the chance of developing an eating disorder is higher with first-degree relatives, say a mother and son, for example. We also see higher rates of eating disorders in identical versus fraternal twins, which again gives us an idea that there is a genetic component to eating disorders.
The impact of the home environment and our families is also paramount. So studies show that a single cutting comment by a parent regarding weight has more effect on shame and body image than repeated teasing by school peers. It came out really recently. So that's why I often collaborate with families too, and I can go into that as well. Just because parents can also directly and indirectly communicate to us values regarding food, even from what is available to consume in the home and what is not. And if it's not, it's often seen as forbidden or bad, or comments parents may even make about themselves and their appearance. For instance, I was once taking care of a toddler and he was looking at himself in the mirror. He looked at himself first, straight on. Then he looked at himself from profile, from the side. When he did that, he disliked how he looked from the side, but he liked how he looked, looking at himself straight on. But from profile, it was almost like tugging at his skin, at his stomach, that he really disliked it. And I asked him, what made him even think to look at himself in such a way in a mirror and to have such thoughts? And he just said to me, Mom, it's just so heartbreaking, right? We don't even realize it. It's like, kids really pick this stuff up. Individuals, they sometimes may also have no concerns about their weight or appearance until someone brings attention to it. And culture is also really great in this as an indicator. So for instance, there was a study in Fiji that showed how American entertainment, especially sitcoms, changed how women saw themselves and their bodies. One woman even said in one of the interviews, I want to be like those women. Whereas in the past, weighing more was associated with wealth and vitality. And as you mentioned earlier, certain sports and careers also have an association with disordered eating.
If someone is concerned their loved one might be struggling with an eating disorder, what are some signs they can look out for?
So skipping meals is a big one. This might be because they are restricting or because they binged earlier that day and are too full to eat. They may become more isolated and hesitant to make plans, worried about being seen in public and how they may be perceived, not just by the person they're eating with, but other people around them. They may no longer want to go to events that are food related in any way. And also at the beginning, you may notice an increase in the frequency of comments about weight, diet, and appearance. And there's also a term that's come up, orthorexia, sometimes used with individuals who want to eat only pure or clean things. Or people might suddenly develop food allergies they didn't have, and suddenly they're basically eating nothing or not eating the foods they used to. Exercise can also be a sign. So for instance, someone may get hurt, be injured, be told not to exercise, but no, they will exercise. If they are sick, if they are injured, they need to get that exercise in. And also there's that control piece again, wanting to have a sense of control with regards to food, such as being the one to serve everyone at dinner so as to have control over portion sizes, needing to pick the restaurant, and getting upset at times when plans get rescheduled for later. For instance, they could have been restricting and really looking forward to that plate of food. Also, we can just be curious. What happens during meals? Is the food eaten, avoided, strewn about? Is someone going to the bathroom immediately after? And also, we just notice our friends and loved ones change. Mood is altered. We naturally become distractible, irritable when hungry. And when faced with an eating disorder, a person may seem to fade away, like a shell of their old self. And sometimes part of getting treatment is starting to feel alive again, to feel all the feelings, and doing so can be really scary.
Thank you for listing all those things. In the recovery process, what is it like? What are some of the common roadblocks that people face towards recovery and management?
It really varies and depends the road to recovery on the severity and the type of eating disorder a person is struggling with. For instance, someone, like you mentioned so well, like we see things like the bones, all the health factors. If someone has something like bradycardia, which is a really low heart rate associated with anorexia, we often want them to get medical care first, and then they may be able to transition to a residential level of care. Things like that, because we want to ensure safety. And severe binge eating and bulimia can also necessitate a higher level of care, such as residential or partial hospitalization, based on their health status. And also, are they able to function? Are they able to go to school and work, or is their mental health impacting their ability to do so? When we look at outpatient treatment, ambivalence can be a big roadblock, especially with anorexia, because again, it's seen as a part of their world. Very, very hard to let go of. And if someone is a minor and under the age of 18, they have to go to treatment because their parents say, that's also a really hard starting point. And just food, appearance, these are such intimate and culturally loaded and personal things, especially in our society when we're just overwhelmed with images. It can be so hard to talk about. It can feel really shameful. For instance, I once had a patient who had an eating disorder for 30 years, and I was the first person she used the word bulimia with. I was the first person she told. In the process at first, it really includes creating that safe space, one that is comforting, warm, understanding, validating, and also just expressing how it makes sense that the individual would cope in the way that they have based on their life circumstances. So the process and pace is also really, really collaborative. And another really important thing is weight loss goals are contraindicated with individuals with eating disorders. We want to treat the eating disorder first. We do not want to feed the eating disorder. And also, identification of emotions is very important. And there's even a term, alexithymia, that's often seen with people with eating disorders. It's like they can't express the emotion or really feel emotions. And again, that lack of nutrients, all of that, it can just be a deadening or just like a sense of numbness. Often what we want to do is just identify emotions. It's really important before, during, and following an eating disorder behavior. Questions are, what is driving this? What is the root cause? I also like to help stabilize emotional states and reduce eating disordered behaviors. So based on the patient, I may teach them a variety of techniques to help address the emotion that may drive the behavior. I also really strongly believe in the neuroplasticity of the brain, in our ability to heal and to change ourselves. We now know that our minds are constantly changing. So the wonderful thing about that is if we change our behaviors, we create new neural networks, new ways of acting and thinking. We can have that become the new default, with the old behavior or thoughts fading with the lack of use. while the new pathway becomes stronger. So with restricted eating or only eating certain things, I may ask patients to purchase something new each time they go grocery shopping. And I say it can be any aisle, any department you like, just get something new. And also what I want to do with that is to increase the variety of foods consumed and to remove any connotation of good or bad or any moral association with food. And a roadblock patients with anorexia or severe thought preoccupation may have is, I've weight restored. I did it. I stopped restricting. Why am I still having these thoughts? And the answer is the behavior might have been easier to change, or we may have seen the physical changes such as weight restoration sooner than the cognitive. And that's because restriction is, a few times a day, but thoughts can be endless, repetitive, hundreds of them. So we really need to challenge them, look at alternatives, evaluate, what does it mean about me? And also with treatment with eating disorders, there may be a lot of progress and patients may get really discouraged if they have what they view as a slip. So for instance, skipping a meal, thinking maybe very black and white. Progress is not perfection, nor is it linear. And perfection is the enemy of the good, and often a trait underlying anorexia, that perfectionism. And I see the same with my binge eating or bulimic patients. Their trajectory is upward, but when a binge or a compensatory behavior occurs, they may think, that's it, I give up, I'm back at square one. It's that black and white thinking again. So a pint of ice cream may as well have been 1,000. It's not. That's where we incorporate mindfulness. Okay, there was a binge. It's over now. Or okay, there was a meal that was skipped. The time for that meal has passed. But now we can eat a snack or our next meal. We can keep going. We're still on the road to recovery. We can resume having meals as a normal part of our day. Progress can also be measured in many ways, from a reduction in eating disordered behaviors or medical markers. It's also about the content patients bring into session. Are other emotions coming up? Has their view of the world and their identity widened? Has thought preoccupation reduced? Has joy increased? I don't focus solely on symptom reduction, but also an elevation of overall well-being or self-actualization. Who do they want to be? Who are they without the eating disorder? What activities or goals would they like to pursue? And whenever there is a behavior that is distressing to a patient, whether it's eating disordered or not, I often ask myself, what function does it serve? What's the point of this? What purpose? Is it to self-soothe? Does it manage anger? Is it coping with trauma? And then I'll ask my patient about it more literally once rapport has been established. Does it serve any useful function? Does it solve the problem? For instance, will spending $100 on takeout solve the fact that I feel badly about a text I received from a friend, an email from a coworker, or a negative comment about my appearance? The answer is almost always no.
Any resources for individuals with eating disorders that you can mention that might help them find a way towards the care that they need?
Definitely. So the National Eating Disorder Association website is wonderful, informative, and helps connect to resources and providers, and even has chat and text availability now. Books I often recommend to patients are Life Without Ed by Jenny Schaefer and her psychologist, Tom Rutledge, Eating in the Light of the Moon by Anita Johnson. On Instagram, I really like The Fitness Chef. He's a nutritionist, and I'm going to mention his name because it turns out there are a lot of people with that handle, and I want to make sure it's not misinformation or directing people to the wrong source. His name is Graham Tomlinson. So Graham is Graeme, and Tomlinson, just like it sounds. And he really dispels a lot of myths regarding nutrition and also goes into the psychological processes that occur with believing these things.
Those are great resources.
Thank you. I'm glad to help.
Yeah. Do you have any final words of wisdom for people who, have eating disorders, or people who have loved ones who have eating disorders?
Certainly. And something that I do at my current practice is also family therapy. Okay. So it can be really helpful, especially with teenagers. And the goal of family therapy is to provide psychoeducation and also to foster communication produce distress. And I want my patients to have more independence. And again, control is such a theme, more control over their lives. So we often make an agenda beforehand so they can kind of guide the session. And my goal is, again, so that one day they don't need me for this. And another thing I do is provide one-on-one psychoeducation sessions for loved ones who have someone who has an eating disorder. And this can be, parents of a child with an eating disorder. And sometimes the child may even be an adult, but they're really close and the relationship is really struggling because of this. So it can be really informative for the parent, strategies, research, knowledge. And also, I touched on this briefly, advances in technology, that is also a big trigger. So for instance, before advances with social media, we used to worry all the time about magazines and TV. Now that there is social media, there is Facetune, filters, and people promoting all sorts of unhealthy diets or giving advice online. So be careful who you follow. There is a lot of misinformation out there. And make sure the source is not only someone who is knowledgeable. Yes, they may have a degree, but do they have a specialization or degree relevant to eating disorders or nutrition? If you feel worse instead of better when seeing someone's account, unfollow. Really don't believe in tracking food consumption on an outpatient basis. So eating disorders, they already take up a lot of time and we don't need to add to that preoccupation. Shame may also result. And I've even seen pages where a teenager wrote her diary, perfect penmanship, just trying to stay below a certain caloric intake, each even cross multiplying and dividing, trying to see what % of calories were from food or from other sources. And frequent weighing is also to be avoided. And I like my patients with binge eating and bulimia, especially not to do so. As seeing the number itself, whether they view it as a positive or a negative, may lead to a binge. And this is either often due to disappointment or a fear of failure. Like, oh, I lost weight. What if I gain it? Binge, relieve that anxiety. And studies also show that individuals who weigh themselves twice a day or more are more likely to be anorexic. And there is a significant correlation between anorexia and OCD. And I've had some patients who weigh themselves 6-7 times a day. Wow. And we know that our bodies, and especially with your work, that our bodies, we can weigh 5 pounds differently from one day to the next.
Especially
completely normative.
Female anatomy, yeah.
Also exercise. Being really gentle with it. So I like to reframe it as joyful movement. It shouldn't be something you hate or feel you have to do. And you'll be less likely to engage in any form of exercise and then miss out on all the other benefits: sleep, improvement in mood, reduction in anxiety, endorphins, all that good stuff. And it's also really important to check in with ourselves and see if we feel ready. So for instance, I once worked with a patient who successfully recovered from anorexia on an outpatient basis. And she was cleared by her nutritionist to exercise. And speaking to your earlier point about collaboration, I'm often in touch with other providers, things like that, just to make sure we're on the same page. And it's also really important too, if we might need to bump up someone's level of care, to have that treatment team all being on the same page. So just, and I spoke to her nutritionist as well. She was clear to exercise. We both agreed she was doing well, but she didn't want to exercise. She didn't feel ready. And I supported her decision because she wasn't ready. And when she did it again, I think it was weeks or maybe a couple months later, and it didn't trigger any eating disorder thoughts or behaviors, which is what we really want to look out for.
Absolutely.
So listening to our intuition is so important. And this is something that I sometimes see with parents of athletes. Like you mentioned with dance, it comes up so much with athletics or certain careers. We see an increase in eating disorders. Sometimes parents of athletes, they may encourage their teens to go to the gym, even knowing their teen has an eating disorder. And it can be really distressing to exercise again. So something I often do is make coping cards with patients, if that's their style. Because again, every patient is different. And coping cards, they can be helpful with a variety of topics, whether it's urges, emotions, difficult situations. And often for exercise, I'll add a line that says, because I want to. And I add that line because I want to. not because someone else, whether it's a parent or an eating disorder thought, wants to. For loved ones who have someone in their life with an eating disorder, patience, kindness, love, reassurance. Don't point out eating disordered behaviors, especially while eating, which is already a really highly emotionally charged event. Saying something like, I notice you've been sad lately, or not like your old self. Is there something you'd like to talk about, or something you like to hear? And then listen. We often want to be solution focused. Just eat. That's all you need to do. Or try this or that diet. That's not what's helpful. Provide comfort, support, reassurance, validate the emotion, the distress, because it is really, really distressing. And also, if we know someone has an eating disorder, it's so automatic, so ingrained in our culture to just comment on what we eat or how we think we look or about diets. So we really try not to engage in food talk around loved ones with eating disorders. So for instance, we might comment on someone's weight loss, and that may actually trigger a loop of thought preoccupation, such as people are noticing, they're noticing I'm thin, I need to keep this up, and that just adds pressure. And saying someone looks healthy may be really triggering for those who have weight restored. Healthy to them could equal fat and different. And these things, comments on appearance, if we know someone has an eating disorder, it really only serves to reinforce the importance of weight and appearance by having another person chime in. And also, if we want to support someone, don't be afraid to ask what is helpful. It may be really surprising. So for instance, many of my patients really enjoy having meals with others. I've even had meals with my patients. They like it because it's distracting and takes the sole focus off the food. This can even be with FaceTime or a simple phone call. And some schools even let students eat lunch with a guidance counselor or parent. And other activities when socializing may also be helpful, because it really takes the pressure and the focus off of food. So for instance, instead of going to a bar, a cafe, or a restaurant, we can do other things. Other pleasant activities exist. And Dr. Linehan, who is a really famous psychologist who created dialectical behavior therapy, she made a famous list decades ago that has been continuously updated and added to by others. And really, my goal with eating disorders is to foster and focus on other aspects of the self besides weight, as patients recover and rediscover who they are and can be without their eating disorder.
Thank you for listing all of those resources. I think, if anything, all the listeners know that this is, a very detailed and very specific course of treatment. And everything that Dr. Pekala has mentioned is coming from expertise and from being a master in this specialty. So if you are someone who has an eating disorder or someone, be sure to get the proper care so that you can make that full recovery and lead a fuller and happier life. So thank you so much, Dr. Pekala, for sharing, your time with me and all this wisdom and all these resources, and speaking so compassionately about, the experience and, the road to recovery for someone. So I think that this is an amazing conversation we had, and I hope anyone who listens will take from it as whatever they need so that they can move forward on their journey.
Thank you so much for the time and the space to talk about it, because it's something that's so hard to talk about, and it's so important to have these conversations. So I really appreciate you having me on.
Thank you.
Of course. And thank you to all of our listeners. Tune in next time for another informative chat. Take care.